All right, everybody, it is officially time to get started. Today, we are going to do a rapid 30. And what we're going to go ahead and do over the next 30 minutes is we're going to do a whole bunch of practice questions together. So let me know in the chat if you are seeing and hearing me, okay? I want to make sure all of our tech is working before we get started. Everyone's seeing, hearing me okay? Awesome. Really glad to have each and every one of you here. I will try to keep up with all the different chats going on, but I may be a little slow in the chat because there's way more of you than there are of me. So if you do have something that you have a question on in Zoom, put it in the Q&A. If you're joining on TikTok, Facebook, or on YouTube, you can put it in the comments there, and I will try to keep up with all of those. So let's get started. The nurse is planning care for a client admitted with infective endocarditis. Which assessment finding would indicate that the client is experiencing a complication? So what do we think here? What do you want to do as your answer? So what I want you to do is I want you just to look at A. Do we like A? Do we not like A? What do we think? Then look at B, then C, then D. Lavender on TikTok just joined to say, pass NCLEX using you guys. Thank you. Lavender, I'd love to hear any feedback you have on the Archer product. Would love to hear what you liked, what you didn't like. Maybe if you feel like we need to add something, let us know. All right, seeing lots of answers coming in already. We're definitely mixed in our answers. All right. So infective endocarditis. What this is asking is, are they experiencing a complication? It's not saying that this is a finding of infective endocarditis. It's which of these is a complication. So when we think about infective endocarditis, would we see a petechial rash? Yes, I agree, Lavender. Do the entire test bank and the CAT exams. Makes a big difference. But would we see a petechial rash potentially with someone with infective carditis? Potentially, right? So should they have flank pain though? This would be abnormal. This would be a concern for me, okay? And then headache. Okay, they might have a headache. And how about a fever? Well, they have an infection going on, so I would expect a fever, which means that B is our best answer. Why? Because their kidneys can actually start to have complications. Their heart can have complications. They can go into heart failure. So what it tells me, if they get bad flank pain, their kidneys are probably struggling. And I would need to make sure that I'm assessing that and that I am intervening. Headache, fever, rash, we're going to expect that. That is something we always see in infective endocarditis. You needed to know this is what tells me there is a problem with the client. Does this first question make sense? Everyone good on question one? Want to make sure we're starting off strong here. All right, I'm seeing yeses, so we're going to keep moving. Question two, the nurse is caring for a client in buck traction. The nurse plans on elevating the head of the bed to how many degrees? Okay, they're in box traction. Knowing your traction types is really important. You could definitely get tested on these on your NCLEX exam. Okay, amazing. All right, I'm seeing some right answers. Put your final answers in, and we're gonna go ahead and talk through it. So with box traction, we do not want them sitting up, right? It wouldn't even make sense. They couldn't even be in box traction if they're really sitting up, which means automatically we're seeing that B and C would likely be eliminated from that. So then it's the question of how far can they truly have their head of bed? And our correct answer here is A. It can only be at 15 degrees. The top is 20 degrees. We cannot go higher than 20 degrees. The reason why is if they come up to that 45 degrees, they actually will come out of alignment with their traction. Now, for those of you who chose 45 degrees, I am guessing, were you thinking of when someone has increased intracranial pressure and we keep them from 30 to 45 degrees? Was anyone kind of thinking that way? Thanks for all that have shared the live. I appreciate it on TikTok and Facebook. I appreciate that. But that's probably what some of you maybe were thinking about there. All right, here's our next question. The nurse is teaching a client in her third trimester about fetal movements. Which of the following client statements would indicate a correct understanding? All right, what do we think? What do we think? Okay, I'm seeing some good answers. Great job. Great work. All right. So 5 movements in 1 hour is considered typical fetal movement. Typically, we want at least, 10 in an hour. So I would say no to A. B, I should empty my bladder before measuring fetal movement. That really it's not going to impact a whole lot here. Drinking non-sweetened beverages may increase the amount of fetal movement. No, it would probably need to be something a little sugary. 10 movements in an hour is considered typical, which is correct. Answer D. If you think about it, either A or D was likely correct because they were similar but saying slightly different things there. All right, here's our next question. The nurse in the intensive care unit is caring for a client being treated for necrotizing pancreatitis. Which of the following findings would indicate the client is experiencing a complication? So what do we think with this one? You guys are doing awesome. Let me know in the comments. Do you guys like this style for free webinars and lives? Is this helpful to go through the questions like this? Awesome. Amazing. Okay, so for this question, we want to know if they have a complication. So make sure you don't answer this as what is expected. Make sure you answer this as what is the issue. Because if you go through and you say, oh, this is expected in pancreatitis, you will get this question wrong. You will get this question wrong. So I want to make sure that you are confident, you're trusting your instinct, okay? All right. Let's go ahead and look at this. So several of you are like, A is the answer, but what do we know about pancreatitis? It has 2 signs. We have Cullen's sign and we have Turner's sign. And I know my handwriting isn't beautiful. So we have Cullen's sign. That's where that bruising, I remember it as a C. If you put it around your belly button, that bruising would be Cullen's sign. Turner's sign is at the flank where you turn. Okay, if there would be bruising there. Abdominal pain rated out of 5 out of 10. Well, I would expect them to have abdominal pain a lot of times with pancreatitis, right? It's literally eating itself. When you think of pancreatitis, the pancreas is, that's going to be painful. It's not going to be enjoyable. White blood cell count is elevated. I would also expect this, but a decreased lung sound in the left lower field. What does that tell me when my lung sounds decrease in one of the fields? What does that tell me is happening? A collapsed lung, right? If I stop having breath sounds in one part of the lung is likely collapsed. And what can happen is they get a lot of inflammation, and it can affect, especially with the necrotizing pancreatitis, where it is affecting their lung. This isn't necessarily a full tension pneumothorax. Typically, like tension pneumo is going to be more, I'm trying to think of how to explain this the right way and what would make sense, is like they get a wound to the chest and air is sucking into that wound and it causes the lung to collapse. It's typically more traumatic, if that makes sense. And then with the tension pneumothorax, what's the main symptom we'll see? Anyone know what that main symptom is? We're going to see tracheal deviation, but to what side? Is it the affected side or is it the unaffected side? Good. Yeah, it's going to go to the unaffected side, right? Because that air or that blood, it could be caused by trauma to the chest wall and blood is filling up, is pushing that lung. Very good. All right, the nurse is caring for an older client with delirium for the third time in the past 4 months. While reviewing the client's medical record to determine the cause, the nurse should prioritize reviewing the client's what? What would we need to review here? Put your why. You guys are all getting this right. I see tons of right answers, but what is the why? Why are you choosing the answer that you are? And again, thank you for all those sharing the live. We appreciate it. All right, good. Polypharmacy. So yeah, maybe I would want to look at vitals. Like I would look at A, B, and C. But what the priority is I look at their current medications because there's 2 things that can really happen. There's one, not an improvement in 4 months. They're on their 3rd visit. But 2, what we see is a lot of times they have polypharmacy. So they see different doctors for tons of different things, and they don't always remember all the meds they're on to tell the doctors. And they end up being on so many medications that overlap that they're on meds to treat their symptoms caused by the other meds, that the medication is truly what's causing the issue. The other thing that can happen in older adults is sometimes they forget that they've taken their medication. So what could be happening is this client could potentially be taking too much of the medication, and that could be causing these effects as well. There are tons of resources out there today that can help with that. I took care of a guy when I was in college, and he had the coolest thing ever. His meds would open when it was time for him to take them. So he couldn't remember like when to take them or what to take. So we would just pre-stock his medications for the week, and it would just open up when he was supposed to take what he needed, and he could do it that way. So it's about finding what's going to work for each client based off their specific needs. All right, here's our next question. The nurse is admitting a client newly diagnosed with acute pancreatitis. The nurse should anticipate a prescription for which medication? And I'd love to hear from you guys. When is your NCLEX scheduled? When is your NCLEX scheduled for everyone? Love to hear how you're prepping. What's that prep look like? Ooh, the 31st, you got 5 days. April 1st, some of you in May, several of you on the 30th. So I do want to, before we go through this answer, I want to kind of respond to this statement in the chat. Someone said, I'm scared. I'm nervous about it. It's normal to have nerves when it comes to your NCLEX. Guys, anytime something's really important to us, we're going to feel nerves about it, and that's okay. It's okay to feel nerves. But what I don't want it to do is I don't want it to control you, okay? I don't want it to control you, because if it does control you, what's the issue with that? Well, the problem is now you're not going to be at your best during the exam. And so what I want to encourage each and every one of you to do is I want you to remind yourself that you are capable, you are worthy. Put in the prep. Like if you are using Archer, I don't know what all of you are using, but if you're using Archer, I want you to get 4 highs or very highs consecutively on readiness assessments. I want you to make sure that you have gotten 80% through the Q bank. And I want you to have done a few CATs so you're used to how the exam adapts to you. All of you should plan for 150 questions. And if it shuts off before, then it's okay. But it might not. It might not shut off before then, and that's okay too. And then you should plan to take a break at question 86 and again at 115. Someone said, hey, do you do one-on-ones? I do. I do them just on request only. So if you are someone who is looking for that, you can email me. My email is rachel.taylor@archerpulse.com. I can drop it in the Zoom chat for the person that was asking for it. Okay. So let's go through this question together. When we think about acute pancreatitis, it is super duper painful. So when I'm thinking about the answer, I'm thinking about what med makes the most sense here. 3% saline infusion, that's just a ton of sodium, right? And so when we think about sodium, we would give that to someone who's maybe hyponatremic, who would need a hypertonic solution, but we don't really need a hypertonic solution here, do we? We do need pain management, so we're going to keep B on the table, and then we're going to look at C. diphenhoxylate atropine. I know what atropine is, but I'm going to be honest, guys. I don't even know 100% what the first part of that is. And so because I don't know it, I'm going to get rid of the answer. Again, I know what atropine is, but atropine in this case wouldn't even make sense to me. So even though I don't know the beginning well, I'm just going to say no. And then sucralfate, that sucks into the ulcers. And so because it sucks into the ulcers, it coats them before food is eaten. So that way it helps with pain, which leaves me only B as my best answer. Now, did you guys all notice how I only looked at one option at a time? I didn't read all four and then choose what I wanted to do. I looked at just one option at a time, went to the next, and eliminated as I went on. I highly encourage that testing strategy for anyone who is prepping for truly any exam. Amazing. I had someone jump on the Zoom chat who said they passed in 2024 with us. Thanks for hopping on. All right, here's our next question. The nurse in the ED is assessing a client with anaphylactic shock. Which of the following findings would support a diagnosis of anaphylactic shock? What do we think? Good. Seeing some right answers. So typically they're not going to be hypertensive. A lot of times in shock, right, they're going to be hypotensive with tachycardia. I don't necessarily expect crackles in the lung fields. That would be more like if someone was in a fluid overload. And then cutaneous cyanosis doesn't make sense for here either. So I'm going to say D, pruritus, right? Because if someone's going into anaphylaxis, they get really, really itchy. And so what can happen is they start to vasodilate everywhere. They also can experience a lot of chest pain, and then typically they struggle to breathe, and that's where we hear wheezing. But if we hear crackles in the lungs, that tells me there's fluid, and this isn't a fluid issue here. Amazing. Rizlam just came on and said, thank you, Archer. You guys were my platform of choice on my second attempt on the NCLEX, and I passed. Congratulations. Welcome to the nursing profession. We are super proud of you. I'd love to hear what you feel like made a big difference using the Archer platform, or if you think we need to add anything to our product, let me know what that is. We're always seeking that feedback. All right. The nurse is assessing a client with age-related cataracts. Which of the following assessment findings would support this diagnosis of age-related cataracts? I'm going to be very honest. The eyes are not my favorite. Like as an ICU nurse, like the eyes were never my focus. And so the eyes are tricky for me. So let's see if you guys can get this right. And I saw someone ask a question. Let me try to find it. Somebody asked, do you do sessions with case studies? That's my weakness. So in our live lectures, if you have our Sure Pass or Intense Prep package, every Wednesday we go through a case study scenario on a client. Every Friday live, you also get the recording. We go through an unfolding case study, NGN style, through the 6 steps and work on the 6 steps. And then you get the recording for those as well. So I would highly, highly recommend, considering if you're looking for more of that case study work, make sure you get the Sure Pass or the Intense Prep packages. That's where those are going to really stand out. All right, let's look at this. Peripheral vision loss. Okay, that's not really cataracts, right? Same thing with central vision loss. What I do expect to see here is they will have difficulty seeing at night. So I'm going to say yes to C, and I don't expect that blurred vision. So let's talk about this. When someone has peripheral vision loss, what do they have going on? Glaucoma. Then central vision loss is macular degeneration. So peripheral glaucoma, central macular degeneration. And then the other thing, headaches, blurred vision. We don't expect that they're going to be getting these headaches with their cataracts. So that would be abnormal. All right, everyone. That brings us to the end of the questions that I had prepared for today. what questions do you have? What questions do you have? Now, someone just said, hey, I have SurePass. I want to know if it's updated with the new changes in April. We have a whole video on that. But yes, and if you look in your on demand, you will see that video. Let me show you where to find it. So it just got uploaded this morning, so I actually haven't seen where it is myself, but let me show you where that video is at. So can everyone see my screen? I might have to change my screen on TikTok. Let me change it quick. Figure out how to change it is really the statement. I wish I was so much better at tech, but I'm just, let's see. Nope, that's not what you guys need. Sorry, I'm trying to find the right page on TikTok. It's going to take me just a second. Okay, I think it's this one. Okay. Let me. Okay, are you guys seeing it now on TikTok? And let's make sure that you guys are all seeing it on Zoom. Perfect. It looks like all of you guys are seeing. All right. So if you go to the dashboard here and you go to the on demand, so under the video library, it's under 2026 NCLEX updates. So you could go ahead, you can watch any of this video, and it is going to have the key parts that you need. So 2026 updates, kind of what you need to know, all of that is here for you. So if you have any questions, feel free to let me know. After you've watched that video, you can always email me. Let's see. I don't have all high assessments. I've mixed with borderline results, but my inside feels ready. I would really make sure to get those 4 highs or very highs in a row. My recommendation is to only take readiness assessments when you can truly focus on it. And I get it. It's hard to study with a newborn. I had a baby in nursing school myself. And that can be really, really challenging. So I would definitely recommend, making sure that you give yourself that time when you need it. Okay. Glad to hear the feedback that you have on Archer. Let's see if there's any other questions. When do we go live? So one of us goes live every day of the week. It just depends on the time. I do Mondays and Thursdays. I recommend following a study plan. So if you're utilizing Archer, you should really be following a study plan and completing one before you take your NCLEX. So here's all of our study calendar options. The 3-week plan, I really don't recommend. The minimum I like to do is 4 weeks. And then the 6-week is the general plan that I have most people do. 9 weeks is for those who are working 312s, and 12 weeks is for repeat test takers. So that's kind of what that would look like. And so let's take a glance at, a 6-week plan. This is what it would look like. It tells you exactly when to do readiness assessments, exactly when to take a CAT assessment. And so it truly takes out the guesswork. It tells you everything that you're going to need to do and when to do it. For a discount code, you can try I Love Archer in all caps. It might work. I'm not sure if that code is still active, but you could try I Love Archer if you're looking for a discount. The webinars are recorded. The only thing not recorded is private and small group tutoring isn't recorded. But the webinars would be recorded. Any of these free webinars we do get posted to our Facebook. All right, everybody. Thank you so much for joining us today here at Archer. If you have any questions, you can always email me. My email is rachel.taylor@archerpulse.com. If you're deciding what package is best for you, SurePass 90-day would be my recommendation. It does come with our exit exam. So if you haven't picked one yet, that would be my best recommendation. But I wish you all the best. Good luck to